Moving on, we want to talk about in greater detail the evaluation process. Some people see the evaluation process as a negative thing, and what we really need to start understanding, especially as advanced level providers, that evaluation is the sharpening tool that keeps us able to handle patients in that priority setting that we find ourselves so many times. So a medical director will have an individual that is responsible for going over reporting and how you write run logs and how patient care is given, and that information is trended. The idea is, as it says here, continuous improvement, meaning if we can identify problems and errors in the system that are being repeated, we can work towards removing those errors and get a greater system, a stronger system, and overall better for the community healthcare program. And the other side of that, we can also identify good things that we're doing, good patient care that's happening, and that can be distributed through the services as well. Another thing that we see is that the trends across the country, if we have an area where we're having a lot of elderly patients with respiratory issues, then that may be a situation where that patient is an identification for a greater problem. Maybe we're having a new influenza breakout in a certain area, and because it's being trended under continuous improvement and quality of care, we can have notification moving forward to other areas of the country and actually have a greater chance of preventing long-term and dangerous outcomes to patients. And that's really important as we move through in this big nation. One disease. Look at the bird flu. It came in, and within less than 6 weeks, it had crossed the country, and that's just an amazing span. As people move around with airplanes and bus rides and whatnot, something like that can be transported. And imagine if it was a more lethal strain of something. The big scare in Dallas, we had somebody come back with Ebola. And it basically locked down Dallas at the hospital that they came through. The nurses were even interviewed on the TV from, what was the exposure like? How did you feel treating this patient? Were you scared? So those kind of reviews of those situations only make us better. I tell the medics, to get a sharp knife, you have to rub it on a stone. And to make us sharp, we have to be, sometimes put in some tough spots where we feel that we're being rubbed the wrong way. But we usually come out of it improved and a stronger, sharper medic. Information systems, we actually can look at scene times. We can improve how we're staying on scene. I've had medics that I let go that worked in services where I was in charge of patient care, where they would brag about emptying a drug box on location, and the call wasn't that they were in a massive traumatic event that had to have a long extrication. It was they wanted to sit on scene and push all the drugs they could when the hospital was less than 10 miles away from their location. They could have easily gotten to the hospital to where there's a person called physician and a staff of nurses waiting and willing to assist this patient in the care. If you're looking to be Superman, this is not the career field for you. We are a team. We are a team that starts with first responders and goes all the way through the highest specialty physicians, and we work together for continuity of care. And that's what information systems and document control is all about, and that's how we move forward to get the best patient outcomes we possibly can. EMS instructors, it's a secondary certification that you can get, and you can get it after you have your EMT. There are EMS instructors that are EMTs. In Texas, there's a class that you have to take, and there's some testing involved. There's some national organizations that you can be involved with, and just like your EMT certification, you have to maintain CEs and be actually working. They want you to actually be teaching classes so that your educational skills don't degrade, just like your skills would be if you're an EMT. To go along with that, every certified person in Texas and around the country has to have continuing education. It's a little different for every license, but it has to be there. It's not there as a money game. It's there because if you don't use it, you lose it. If I asked a paramedic that hadn't treated a neonate in 15 years, hey, what's the average blood pressure of a neonate? They'd probably look at me and go, well, if they're staying up on their training, they could quickly determine, what age, what bracket, and, just kind of puke up the information as they need to, and that it's only done through continuing education or continually hands-on training with that style of patient. Public education, I worked in an area one time that we were right on the coast, and we had a real issue with industry in the town just north of us, and we constantly had these problems with these sloughs and these chemicals spilling into the environment, and people would be swimming in these environments, and we'd have these rashes and these chemical burns, chemical exposures. And it was a big part of what we did was educating the public on the dangers of our area. It may not just be the water, it might be the breathing conditions around the water. It might be the soil that the kids were digging and playing in, and you know, when you dig in the soil, you end up eating the soil. So there was all routes of ingestion and absorption that these patients were having issues with and becoming a problem for them. So education and public laws you'll be a big part of as an EMS provider, especially as an advanced level provider. Public prevention is the emphasis on keeping people from getting further down sick. If you know that we have an area that people are getting sick, being a part of community meetings and talking and educating, talking at schools and working with your patients as you come across them is the best route to not have them become your patient. And that is our ultimate goal to begin with. The last speaker, the one that was in the first session, talked about how EMS research is kind of sparse. Well, I won't disagree with him in how he thought he saw that, but if you have the Google machine, you can kind of find just about whatever topic you want to research and do some individualized training on, as well as training for certification. But like he said, you have to look at that with a skeptical eye. Make sure you're getting it from a reputable organization. Make sure it's not a study by a drug company about how good their drug is, because that's not really something you can trust and train on, because it's going to be biased. It's going to be led to, towards a sales division and less about education. But there are plenty of online magazines that support EMS and fire that can be a part of your constant training. I worked with a guy that was offshore, and our hitches were 2 weeks, and sometimes they could go longer, that he would buy books on taking the National Registry paramedic exam, and every 2 days he would take another exam. And he got so good at taking the National Registry exam that he could continually pop 100% on back-to-back-to-back tests. And we teased him, we joked around about it, but whenever we had a patient with something weird we weren't sure about it, guess who we called? We called this guy who could literally cough up the information in a split second. And it's because he stayed a part of the research and he stayed ahead of the game. He actually got to be a part of some of the writing of some of the books that we use today for continuing education as well as primary education. So research is out there. Be a part of it, and know what you're looking at, and keep yourself sharp. The roles and responsibilities of the EMT: number 1, be prepared. Number 2, be prepared. Number 3, be prepared. I can't tell you that enough. There is no excuse to go onto a scene and then have something bad happen and be wandering around the back of your truck trying to remember where the suction tubing was, or where did we put the 18 gauge needles, or you just don't do that. You just don't do it. Be prepared. And then the other thing is, the bullet point 2 is your safety. Your safety first, then your partner, then your patient, and then bystander safety it should be taken care of and a concern. You've heard it before, because you're already EMTs. Your safety is so important. You can't make yourself a patient. That's why we do scene size up and ask right off the top of the bat. If I say BSI, you're automatically saying scene safe, because that's how we're trained, and that's how we keep ourselves from becoming patient. Operate vehicles in a safe and realistic manner. If you're on a transfer service, that doesn't mean that you need to be running down lights and sirens because you guys are late for the next call. Even if they dispatch you emergent to go to a scheduled call because we're running late, you're not allowed to do that. That's a good way to get yourself in trouble. It's even better way to hurt somebody in the general public. And we must remember why we became EMS professionals to begin with. And it wasn't just to drive fast in big vehicles with pretty lights and loud sirens. It was to protect the general public. And it's our responsibility to be that person. And that person, as the last point says, is to be the leader. If you're on scene and you're ALS, you're in charge. And that's just the way it is. But you can do that respectfully, and you can do that by maintaining integrity as the position details, and making sure that everybody there understands that you will lead and be a leader they can trust. This is going to go through the whole evaluation of patient assessment. When you get into the scene, you're going to start seeing, as an advanced level provider, you're going to assess a scene a little bit differently. It's not going to be the same way when you look on a scene, primarily because in your EMT training, you were assessing the scene to see if you need additional resources of a higher level of care. Well, now you are that additional resource. You are that higher level of care. And when you get into assessing patients, it may just not be for if you need additional resources by numbers, but what you're going to need as far as IV therapies and boluses and medications, and are we going to intubate patients, and then your triage will look completely different now that you're an ALS provider. You're required to give emergency care while you're waiting, and the additional resources I said before may be it may be transferred off to that medic. Like never a time before in your career, when that medic says we need to put this patient down and intubate them, he might simply say, you got the intubation, I got the drugs. I've been there many times where I had a great advanced EMT, and we had a patient that we had to put down so we could intubate him for rapid sequence. And I was blessed to have an EMT that was licensed to intubate the patient and had the skill and the training, and in their scope of practice they could get it done while I could actually handle the medications. And as I said before, that fine line that you are sitting on between EMT and paramedic is so critical for the survival of the patient. I wish more EMTs would take the first step into ALS and get more involved in becoming that next level provider. You only treat patients when absolutely necessary. Again, I said before, this is not a Superman career. You do what you have to, not what you can. Just because you have a license to start IVs on somebody, that doesn't mean you're going to start two 16-gauge 2-inch IVs, one in each arm, on the guy that sprained his ankle at the gym class. You're just not going to do it. Your appropriate treatments should always be there for the needs of the patient, not for the ego of the provider. You will provide emotional support because you're the higher level care provider. They will look to you. The EMT will look to you, and in most cases, your decision of how you handle things will determine how the scene is going to be moving forward. You maintain continuity of care. Whatever treatment you start, you reassess. That was easy as an EMT. You might have given them a little glucose, and you check their sugar again, and you check their vitals every 5 minutes. Well, now you may be reassessing a patient for if your 200 cc fluid challenge worked, or if it wasn't enough, or hey, I'm starting to hear wet lung sounds and I didn't have wet lung sounds before. Did I overdo it? You're going to be questioning how you do things a little bit, but your skills and your training is going to change, and as the way you look at patients and assessment. You will resolve emergency incidents because you are the ALS provider. You are the guy that they look to, or the lady that they look to get things done appropriately. You will uphold medical and legal standards and ensure patient privacy. And like no other time in our country, patient privacy is as important as patient care. I think this is really important, that all the little bullet points they have here, but the last one to me is the standout point. You're going to do your job. You're going to do what you did as an EMT. You're going to do it at a higher level, and you're going to do it professionally. And there's no excuse for handling patients in less than a manner than you would expect for yourself or for your children, and that should be your standard from now on. If we look at these pictures of this same guy, you could be the smartest medic in the world, have every certification that's available, and if you show up to somebody's house, looking like you're not fitting into the role, you will not be taken seriously, and in some cases, you will not be taken as a professional. I had a physician instructor one time that relayed a story that imagine going into a doctor's office, and when you walked into the front lobby, it stunk and it was dirty and there was trash on the floor. And then when you saw the physician, he hadn't shaved in 4 or 5 days, and his clothes were wrinkled, and he smelled bad. He could be the #1 heart surgeon in the world, but you would look at him and go, you're not touching me. Well, our ambulance is our medical office. And there is an expectation when you consider a medic in the field or a firefighter in the field, there's an expectation of how they should appear, and it is professional. And you will be professional. You'll be motivated to be that professional. You'll maintain your appearance at a higher level than maybe you did as an EMT, or maybe it's a continuation of how you already handle yourself. But there is an expectation, and with more education and training, there's more responsibility, and that comes with a higher degree of professionalism. And if you can't do that, then moving up through the chain of of getting to other levels of EMS may not be the position for you. But if you can handle professionalism and maintain that higher level of authority, then you're in the right spot at the right time, and this is going to be a great program for you. You will at all times administer self-control. There will be patients, as you know, since you're already certified, that will push your buttons. There will be partners that will push your buttons. And there will definitely be hospital staff that will stomp on your buttons. But self-control is the way that we maintain our professionalism, and that may mean smiling through some less than positive demeanors and excusing yourself so that you can go yell at a wall instead of a person or a patient. Time management. There is not a greater resource that you have control over than time management. Staying on scene for extended periods of time, in my opinion, is unexcusable. The patients that we have need to get to physicians. We are not physicians. Let me repeat that. We are not physicians. We work under the license of a physician, and we work under the orders of a physician, and our job is to safely and efficiently get that patient to the physician. So we maintain our quality skills and we manage our time appropriately to get the patient as expediently to the physician as we can. Our communication must be top-notch, written and oral, and so that our patient understands what we're doing. We're speaking at the right level with our patients. We're not speaking down to them or over their head. We're not using terms that they couldn't possibly understand. If you tell a 75-year-old lady that her husband suffered from a hemothorax after his, closed compartment chest injury after the car accident, you're just going to lose her. If you said, ma'am, your husband may have some bleeding inside of his chest with his lung, we're going to get him to the doctor and get him taken care of as best and as fast as we can. That's something they can understand. On the other side, when you talk to the physicians and you talk to the medical staff, sure, use the right language. Speak the language of EMS. Be a team player and be diplomatic. You are the lead now. You're the person in charge because you're ALS. Even if you have a paramedic on your truck, you are going to be considered a leader because of what you're licensed to do. You're an invasive license. You have the professional license to be invasive to the human body, which gives you some authority and it gives you some requirements to act in a professional manner. Be respectful at all times, and at no time speak down to your patient or other staff. I have at the top there patient advocacy because that's a pet peeve of mine. I recall a situation years ago where I went out on a call for a DNR patient, and they actually dispatched us out on a DNR with respiratory difficulty. And we get there, and the family had a nurse in the family, and they just wanted us to wait in the front until the patient stopped breathing. And I said, ma'am, I can't do that. I need to go see the patient. And I got to the back, and this lady was cowering against the wall. She was in her late 70s, mid 70s, naked, squatting on the floor, crying. And when she saw us, she started sticking out her arms and begging for us to help her. And the family and this nurse that was in the family said, she's a DNR, we don't want you to do anything. And I had to explain to them, look, DNR means do not resuscitate. This lady doesn't need to be resuscitated. She needs to be treated. She needs to be taken care of. And as we went over there, they actually called the police because we went over and helped the lady to our stretcher, set her down, covered her up, held her hand, and she had some respiratory stuff going on. I think that she probably had a pneumonia that was an issue. She was a little bit hypoxic, and put her on some oxygen. The police show up, and the police sided with us that this lady didn't require CPR or any advanced measures. She just needed to be taken to the hospital. We gave her some fluids and some oxygen and a breathing treatment, and by the time she was at the hospital, she perked up, sats were good, the crying had stopped, and she was warm and toasty and flirting with the other medics. So sometimes being a patient advocate means just being that in between for your patient and either their disease process, as in the case of a diabetic who goes down and then doesn't want to go to the hospital after you revive them, or the situation that they find themselves in, stepping out, and maybe you have a patient that you can tell that their situation is not so much they have a control of, and maybe they have issues with getting food, and you're going to help coordinate some care for them and maybe send some resources their way. But always treat them with compassion and respect no matter the situation. And I say this not so much tongue-in-cheek, but no matter the smell, you'll come across a lot of people that are homeless and living in the street, and their situation may have them not in the best position in the world, and you put them in the back of your ambulance and literally it's all you can do to keep talking to them, because the smell is so bad. You still should treat them with compassion. I worked at a service for many years that we did the transfers for the Department of Corrections, and I was with another paramedic one time, and we picked up a patient, and for whatever reason, he asked the guard, what's this guy in here for? And it turned out that the guy had been in jail for raping elderly women and beating them up, and he'd been convicted for dozens and dozens of years. And my partner was immediately offended, immediately grossed out, if you could accept that term. And the guy was having chest pain. It wasn't cardiac; it was all pleuritic style chest pain, lung pain. And he put the guy in the back, and the guy. Stats were good, pressure was good, pulse was good, and my partner literally sat at the back of the ambulance and just put his feet up on the edge of the poles on the stretcher where the wheels go, and the guy was begging for something for pain, and my partner just said, "You'll be fine till you get to the hospital," and did nothing for him. And we get to the hospital, we move the guy into the hospital, and immediately the nurses come in and they start lines and put the guy on the monitor and put him on some oxygen and that kind of thing. And I cornered my partner. I said, "Look," I said, "No, nothing for nothing, but you didn't treat the guy with the best amount of professionalism." And he came back with, "Did you hear what he's done in the past?" And I kind of said, I don't really care what he's done in the past. It's not our job to judge. And out of that situation came a policy within our organization that we were not allowed to ask one of the inmates what they had done, and if an officer was trying to give up that information, we were to tell them that we were not allowed to receive that information, so that that we wouldn't have a bias towards the treatment. And all that to say, treat everybody with the same amount of respect you would want you or your family to be treated, and it goes a long way in furthering your career and your patient care. The last thing we're going to jump into is HIPAA. If you're an EMT, you've been exposed to HIPAA. There are 3 components that you have to be really concerned with, and that's your policies on patient information, your record keeping, and how you secure that record keeping. If you're in a small town, or even in a town where people get around and talk a lot, they may see your ambulance at someone's home, and you run into a neighbor in the grocery store and they're like, "Hey, saw your ambulance at Jim's house Tuesday night. What were y'all doing there?" You can't give up that information. That's not something you can share. It's protected, and you can be in a lot of hot water if you start sharing patients' private information. Now, that being said, you don't have to come off and say, "Well, I can't tell you anything about the patient." You could simply say, "You're putting me in a really bad spot. I'm legally not allowed to share any information, and I hope you can respect that I can't really tell you anything about the call." You can speak to other people professionally, and they will understand. And if they don't understand, you just simply excuse yourself from the situation. But the HIPAA laws are there for a reason, and you will be glad, if it was your information, that it didn't get shared and lost to the public. So, getting to the wrap-up of this, we want to look at what is an EMT advanced level all about. Well, in a nutshell, it's about acid-base balance. And when I talk about that, we're talking about how acid and the alkaline portions that are regulated in your blood and in your body, the minute changes can really affect how your body responds and whether or not your body survives. We talked about DKA, diabetic ketoacidosis. You go into a patient's house as an EMT and they're in DKA, they're huffing and puffing with those Kussmaul's respirations, are rapid and shallow. And as an EMT, you check their sugar, they're high. You maybe give them a little bit of oxygen, and you want to, they're going to cover them up and treat them for shock and get them to the hospital. Well, as an advanced level provider, you're going to see that the reason that they're using those Kussmaul's respirations or huffing and puffing is their body's trying to blow off acid. They're in a position where the acid level in their body has changed, and it's becoming dangerous for them. And people die from DKA. People get into those positions and they have real problems that require emergency treatments quickly. They start putting off urine. Their body tries to change the way that they're breathing and how they're dumping off fluids just to control acid. That is the primary focus of the advanced EMT, is learning to master the understanding of how the body will put off acid and alkalinity and how it affects the patient in your assessments. That's when I said your assessments will change. When you walk into a room moving forward and someone's huffing and puffing, or they're sweating profusely, or they're peeing profusely, or they've had nausea and vomiting that's been going on for several days, you're going to consider other situations outside of just the main things you learn as an EMT. Well, are they having a heart attack? Well, yeah, that may be something that's going on, but they may also be metabolic alkalosis because they've depleted themselves so much that they're having problems. Did they take, along with their chest pain, 30 Tums over the last 3 days and actually change the alkalinity within their system? So learning acid-base balance is the very first step in becoming an advanced level provider, which goes into what we're going to do before the next class. As I told you before, we consider this a collegiate level program, and we're going to do collegiate level work. So before the next class, you have a writing assignment. It's going to be 800 words, and the topic is acid-base balance. Inside that paper, you need to talk about metabolic acidosis, respiratory acidosis, metabolic alkalosis, and respiratory alkalosis. The paper has to be an APA style. If you don't know that, that's fine. There's a resource called Purdue OWL, and the link is at the bottom here, or you could just Google Purdue OWL APA style, and it'll take you to a site where you can actually download the template and just change the words out for your own stuff. It has to be 12-point font, Times New Roman, and double-spaced. It will have a cover page and a reference page. It should go without saying, academic dishonesty is never appropriate. If you plagiarize somebody, you'll get an automatic 0 on the paper. We just don't accept somebody else's work. So if you turn in, Dr. Red Duke's theory on trauma and acidosis, then I'm going to just give you a big O 0 because you didn't write it. So we have ways of running it through our system to determine how much of your work is you and how much is somebody else's work. Copying and pasting over is never acceptable. You can use other people's work, but you need to read it, think about it, break it down, and explain it in your own ways. When you get it written, you're going to email it to me, and the email is right there, barnes.tech@yahoo.com. And the way you email it is you'll do AEMT, your last name, comma, your first name, and then acid-base balance paper. So mine would be AEMT Barnes, comma, Joseph acid-base balance paper. And you don't need to put so much in the email itself. You just need to attach it, and the line should have your information in it. And that should be all that you're going to do. It needs to be to me before the start of the next class. If the start of the next class arrives and I don't have your paper, it's an automatic 10 points off. And it's 10 points off for every day thereafter until it gets turned in. This is an in-class project, which means we're cutting class with enough time for you to actually start working on it right now. Otherwise, we'd have another bit of time to go along with this class. If you have any questions on the project, you can feel free to email me on the same email address. Just put your AEMT and your last name, first name in the subject line, and then put in the email the question that you have, and I'll respond to you as soon as I can. Those come right to my phone usually, and I'm pretty good about getting back to them. If you don't get me right back, you're welcome to text me. And if you have any questions, I'll be available. Thanks so much, and I look forward to reading your papers.